I'd like to say that I really don't want to give you the impression that we operate in general in geriatric patients frequently, and that we think that a major operation is a solution for all of those geriatric patients. So I try always to speak to my patients, to ask them, how is your life? What do you do in life? And when they tell me, I just stand up in the morning, I go to the sofa, I watch TV, then I say, okay, you don't need a spine to run a marathon. So I try to be very strict with my indications. Sometimes it's necessary to operate on those patients, but I think we all have to be truth with the patients about the high risks, and that the operation itself, it's just a part of the treatment. And I never do the indication for big surgery when I meet the patients the first time. I always send them home. I say, speak to your family, then come back and we can discuss it again. If you still have the wish, then we can speak about an operation. But I will come to this later on. Okay. So I just brought you 4 cases that I treated with the advice system. We saw that in the morning. Yeah, here's a small overview, and I straight start with the first case. And you can see that all of those patients had a severe osteoporosis. And that's another point why I do not do the surgery when I meet them the first time, because I want them to have a specific osteoporosis therapy for at least 3 months. So if they do not have it before I meet them, then I indicate them and I say, okay, we at least need 3 months of specific osteoporosis therapy. Okay, first case here, you can see it's a patient. She was already treated with an internal fixation, and she had a T12 proximal junction fracture. Some more details to the patient. She was 60 years old and had a prior L3 fracture with this instrumentation L1 to L5, and currently the proximal junction fracture. No neurological deficits, but she was complaining about back pain, and yeah, she had a decreased walking distance, and this is why she came into the clinic. You can see that she is malaligned. Here the knees are bended. That's an old injury of the hand, and she said, okay, I cannot live like this. I do not have any life quality. So what I always do is I try to analyze the deformity, and what we do is we use the age-adjusted alignment parameters from Lavage. You can see here that yeah, the SVA is way far away from where it should be, and there's a high angulated deformity in the thoracolumbar junction. So when we analyze those deformities, we use some basic data. I like really much this paper from Lueck, but there are also other papers, you all know them, how to analyze that. I think it's very important to analyze the whole spine, including the cervical spine. I definitely agree that there are some measurements that are just experimental, but you need a clear plan and a clear algorithm how to analyze those deformities to treat the patients yeah, in a good way. So how was my surgical strategy? I thought, okay, we have to do re-instrumentation and enlargement. I can maybe do it partially open and partially percutaneously. I need maybe it's necessary to do some osteotomy at the kyphosis. And what I like to do is I do the compression in the area of the osteotomies with a short rod, and sometimes I change it later to a longer rod, or I do a double rod construct. And then I wanted to do the advice system as I already showed in the morning. So these are the intraoperative pictures. You can see here I did a median incision there, did some osteotomies, and I enlarged it to T4 with this percutaneous technique. And this is how it looks like in the OR. You can see it's exactly the same what we saw today. I go around with this iPad and scan the patient's surface, and then the iPad gives me like a template, and I can bend my rod there very adequately on the besides the patient. And then, unfortunately, the videos doesn't work. I can insert the rod. And what I already told you in the morning, we try to lock all the set screws with just 2 fingers to have no tension to the rod system. Okay, and this was the final result. Unfortunately, you cannot read the distance here, but she's now aligned, and I saw her once in a while, and she's very happy with the result. Another case, a little bit more complex case, you see a severe mismatch of the lumbar lordosis and the PI, and proximal junction fracture as well. And this patient was 70 years old, and she had a prior spondylolisthesis of the lumbar spine. Because of degenerative disease, you can see she has 2 cages here, 2 T-lift cages in the lumbar spine, and then she had a circumferential treatment after L2 fracture, and since 6 months she was in the wheelchair because of back pain. She could barely walk. And I have some clinical pictures and videos here, and you could see that that's her standing position. And even if I say, try to go 2 or 3 steps with me, she's collapsing, and she said, no, that's impossible. Okay. So I analyzed this as well, and what we can see is it's even worse than the other case from her alignment, and this is why she's collapsing to the front. And when we look at this a little bit more specifically, we could see that there is a huge misalignment, PI-LL misalignment of more than 30 degrees. And additionally, there's also a kyphosis in the upper part. So at least I think this patient needed about 50 degrees to be corrected. So my strategy was to perform an L5 PSO and to do some ponteosteotomies in the upper part and to reduce her and optimize the lumbar parameters. And again, I wanted to compress the cranial osteotomies with the short rod, and then I wanted to change it. So I did it a little bit different. As you can see here, I started with my PSO. As you can see here, I do it the same way as we saw it in the lab. I do it with osteotomes, with 3 osteotomes, remove the pedicle, and then I go in with this chisel or with this osteotome. After I remove the pedicle, I go around the dura, and then I press in the posterior border into the vertebral body as a last step. And as you can see here, I always use one. We should always use one protection rod, so that when we do the osteotomy, that we do not lose the vertebral body itself. So. Okay, and this is how it goes there. So I could do almost 25 degrees correction with this osteotomy. This is the PSO, and I did from L4 to S1, and exactly the same way as we saw it in the lab in the satellite technique. So this construct here is not connected to my long construct around it. So this is standing alone. And then I enlarged the median incision. I placed in my rods. I did my osteotomies and placed in the screws. And then I did a scan again. And in the mid part, you can see there are no markers, because this was an old system, and the screws were already fixed, and it was not necessary to change them, so I avoided that, and just did a scan around. And I bended the rod, so it was a long one, and you could see, or you can see that these osteotomies in the upper part, they were able to open the disc spaces, so they're not kyphotic anymore. I could do a relordosis of the thoracolumbar junction with this ponte osteotomies, and I achieved already the lordosis by the PSO. And yes, so as you can see here, here's a PSO. So this is an instrumentation from L4 to S1. And then there is a second instrumentation with a lateral connector. And this is not connected to this screw. It's coming from the ilium to the upper part. And this is an intraoperative picture, and this is a long construct, and the osteotomy L4 to S1 is below this rod, so you can barely see it here on the picture. It's somewhere here. Yeah, and this is a postoperative result. So the distance is where I planted around 6.5 centimeters, and the parameters also. She's now aligned, and these are the postoperative results. Another severe case, distal junction fracture. As you can see, this patient here, 72 years old. She came to my clinic. She was treated with a instrumentation circumferential T7-8 to 10-11 with a cage. And someone thought that's a good idea to make a kyphoplasty below the system, and she suffered unfortunately for some cement in front of the spine. And now she is decompensating because of this distal fracture here. She had some chronic lumbalgia, some other surgeries on the spine, as you can see here, prior L4 fracture here, and after spinal canal stenosis, a decompression, and some severe diseases like morbus Parkinson. But this lady said, okay, I cannot live like this because I cannot stand. I cannot sit because all the screws are straight under the skin. And even after I told her that it's a very big operation for her in connection with the morbus Parkinson, she said, no, I don't want to discuss about it. I have a big family, 2 dogs. I want to go out. And that was not impossible. So again, we use this alignment parameters always. And I did a CT scan because I was a little bit concerned about the cement. I thought maybe it's attached to the vessels, but it was okay. So it was not necessary to remove the cement. And my plan was, again, to enlarge it. I thought it's flexible. I do not have the pictures here, but within the CT and MRI, what we did, it was a little bit flexible there. But I thought, okay, we have to do some osteotomies because of this high angulation. And this is an intraoperative picture. And then I released her. First, I removed the screws and placed in my my new screws. And this is something you get used to. It's not very comfortable to have all those extenders. So when you have an open approach, you can say, okay, this is bothering me. But on the other hand, when you have the option afterwards to make the scan and to have a very smooth bending or contouring of the rod, it really helps you to make it tension-free. And then I did my osteotomies here in this area, and I did a scan again. And this is the final result. It's difficult to see here. I closed it there. And this is how she looked like afterwards. And what I did in that case here, this is something I really like to do, is I go through the disc space. So I try to do very long screws as an ending screw. I go inside in the upper part of the pedicle through the vertebral body, through the disc into the next vertebral body. And then sometimes you can use 70-millimeter screws. And I saw less screw loosening in this area. And I think this is beneficial not only because of the length. I think the length is the weakest parameter for the hold of the screw. But it's also that you have a high distance between the end plate and the screw itself. So this is something I like to do, but I only do it when I navigate the screws. Yeah, and this is straight post-operative, and this here was a 2 years follow-up. You can see she's not perfectly aligned, but she's happy with this result. And she was a couple of weeks in the hospital, and this is another important point. What I think we have to tell the patients that the risk for infection is very high, and not only for infection, for wound healing problems. And this is why I try to do my procedures. I mean, these are all posterior stabilizations, but when I do it circumferential, I try to stage it because when we have a long wound in the back, the patient cannot come out of the bed in the early phase. It can cause local necrosis, and you need wound revisions 1 or 2 times. I think we did 1 revision here for her, but she was happy with that. Okay. So I come to the last case. It's again a horrible case. Old lady had this. She was suffering from this T10 fracture after this instrumentation. She's 80 years old. You had this T11 to L3 instrumentation and a small listhesis somewhere down here. It's barely difficult to see. And she said, okay, I have a very big family. I have to cook for 20 people 3 times a week, but it's impossible. And I tried to motivate her to stand up. She could stand up just for 2 seconds with all her power, and then she was collapsing again. And yeah, we spoke about all the possible treatment options, but she decided for surgery. And yeah, I thought, okay, these screws are loosening, so we have to change the screws. We have to enlarge it again, do some osteotomies. I thought about a spanning rod for the initial reduction, and then a second rod for a soft landing. And that's what I did. So I did some osteotomies with this rod and corrected it with some compression here. And then I did another system from the ilium to T4 to neutralize the surrounding forces. And that's the result. As you can see, it was a little bit difficult in the upper part, so this is why it looks a bit different here. So I just placed 1 screw in the upper level, but I was happy with the result. And she was discharged, and they sent me this video out of the rehabilitation center, and she was walking there, and she said, oh, she's very happy. But I thought, okay, but something is wrong here. She's with the head, it's in the front, and I did a CT scan, and I recognized, okay, I overcorrected her a lot, and my calculation was wrong within the operation. I had some screw loosening here. This is just a fracture. Fortunately, the patient said, okay, I feel good. I can walk now. I don't want to have a surgery afterwards. So she was treated conservatively as far. I saw a couple of times after the operations. Now I didn't see her anymore, but I had not to enlarge it again. So I spoke about the options, but that wasn't necessary. And when we looked here, this was my big failure, my big fault. I overcorrected her a lot. So when I come to the end, I would say it's nice to have a tool where you can have a soft landing, and this, I think, is one key parameter besides others in those operations in the geriatric population. But we should be maximal critical with those operations, because all of those operations are like a marathon for them, and we cannot ignore the complications. We should precisely plan what we do, otherwise it will not work. Maybe we can combine some minimal invasive approaches with open procedures. I think when we have 80-year-old patient with the instrumentation from T4 to the ilium, I'm not really convinced that this will heal. So therefore, I think sometimes you can have an area where you do it percutaneously, and it doesn't matter if it heals or not. You just have to have the right alignment. We have to find the right osteotomies for the right curves, and a soft landing, as I already mentioned, is, I think, one of my key roles. Thank you very much.
Thank you for going through those cases. Some obviously very challenging patients. And as you said several times throughout that lecture, I think it's something we all see. Although they may not be the best candidates with osteoporosis, they're pretty miserable. And sometimes we can make a big difference in these patients' then clearly those were some very great outcomes. So in terms of using the system, do you feel that there was that one case you showed where you had some adjacent segment breakdown. Do you feel that the contouring of the rods more precisely is leading to less pullout of the screws and less stress? Is that something that you've seen in switching, or is it kind of too soon for you to really notice a difference?
I think it's a bit too soon, but I feel that it decreases failure. But one problem is that I think when you place those geriatric patients on the belly, and sometimes even by placing them when they are flexible, they can be overcorrected. And this is something, from my feeling, this cannot be calculated. I think it's really superior to bend the rod with this tool, because it's not only faster, you also need less bending moves. So I think the rod is more stable afterwards. So we all know that when we bend it 10 times, and it gets weakened. But I unfortunately do not have any long results out of it, and there are no studies yet.
And you're typically using the patient-adjusted, sagittal correction.
Yes.
I just wonder, anyone else out in the audience, I tend to, kind of overshoot, and then when I'm not getting the correction I like, I say, well, she's corrected for her age.
Yes.
Unfortunately, but no, I think it can be very challenging also to see exactly where they are.
Yeah.
So with that device that you have, can it give you a reading of what your actual lordosis and kyphosis is from the, I guess, the QR codes?
No, unfortunately not. So there, as I already said in the morning, there is something like a trauma tool where you can adjust the amount of correction you like to have. But it's not possible to measure the kyphosis or lordosis during the operation. When I thought the presentation in this morning with the cameras, I thought, okay, might be a nice combination that you have, that you can correct it, and then a soft landing. This might be interesting. Unfortunately, now that's not possible. Yeah.
Any other thoughts on SVA correction and what kind of your goals are?
Yeah, great. I had a little bit of a different question to shift gears. I was just wondering, in your health system, what is the bone health pathway that you have access to? Our bone health is a little bit driven by the university center or the center you're at. We try to work closely with our endocrinologist, identify osteoporosis, and treat it with bone anabolic agents. And there's only like one medication that Medicare is willing to pay for, and a lot of our patients are in that population. You're in a very different system. Is there an aggressive bone health pathway when these patients get to you? Are they already optimized for the bone health with bone anabolic agents, or is this something that you're on the front lines of trying to take care of?
Yes, that's a very good question. So I think this is a very weak point in our healthcare system in Germany. I see those patients, sometimes they come with this fourth, fifth fracture, not only the spine, also in the pelvis, the radius fracture, whatever. They are not treated sufficiently. So we send them. We also work together with the endocrinologists. We also want to offer them osteoanabolic treatment, but we, for example, do it. We have no access to it in the university hospital, so we have some specialists in the town where you can send them. But I feel that osteoporosis is still undertreated, and unfortunately, all of those patients, for example, they came to the clinic and they had no specific osteoporosis therapy, and this is, it's just sad because hypertension, diabetes, everything is detected early and treated early, but osteoporosis is still like it's not a real disease. Yeah.
All right. Thank you again.
Thank you.